Bismillah ar-Rahman ar-Rahim. This is a suggested protocol for amelioration of the pathogenesis of lung pathology in coronavirus infection in a trial to treat such cases. What's coronavirus? Coronavirus 19 is called COVID-19. It is a severe acute respiratory syndrome coronavirus 2. It's called SARS coronavirus 2. SARS coronavirus 2 is a new strain of coronavirus that has not been previously identified in humans. So COVID-19 is a pandemic nowadays. It's an acute pathology. It is an aggressive lung disease with high mortality. This strain is a new strain of coronavirus, and so far no vaccine. Look at this X-ray. It is very rapidly and aggressively. Look at the X-ray. This is the first day, just ground glass patches here, bilateral infiltrates. Here is severe damage to the lung. Lung pathology is important to understand. There has been several studies describing clinical features of COVID-19 and characteristic radiological findings, but no pathological studies have been conducted based on autopsy or biopsy. Why? Because of the suddenness of the outbreak, the vast patient volume in hospitals, shortage of healthcare personnel, and the high rate of transmission, which makes invasive diagnostic procedure less of a clinical priority. This histology appears in the form of bilateral diffuse alveolar damage, cellular fibromyxoid exudate, discoloration of pneumocytes, high laminar brain formations, pulmonary edema, interstitial mononuclear infiltrates, mainly lymphocytes, but there was no obvious intranuclear or intracytoplasmic viral inclusions. This pathology is an RDS lung, where we describe it in the form of baby lung. The aerated area is very small and the rest are obliterated. Wet lung is heavy, atelectatic lung, with increased alveolar gradient leading to hypoxemia. Management of such lung on the ventilator mandate the use of what we call protective lung strategies in the form of ventilator variables. How much tidal volume, how much level to flush, and so on. In addition to these, you can use recruitment to open these atelectatic alveoli or foreign positioning. And when we fail, we usually resort to extracorporeal membrane oxygenator or extracorporeal carbon dioxide removal. This is done for what? To decrease the lung stress, lung strain, and shearing force, which might lead to ventilator-induced lung injury and oxygen toxicity. But unluckily, usually difficult to save these lungs, and so the mortality is high, usually from multiple system organ dysfunction failure. Ventilator is not a treatment, but it's a supportive one. It's not a treatment. So that's why when you look at the sequelae of pathology, it is an etiology, pathogenesis, pathology, and outcome. Etiology, you are trying now to treat the virus by antiviral and other drugs. Okay, but pathogenesis, no treatment for pathogenesis. And we face the pathology. And this pathology, we give him supportive treatment in the form of oxygen, face mask, non-invasive ventilation, invasive ventilations, and other modalities. And finally, the outcome is bad. That's why the most important part, how to abort or at least ameliorate this pathogenesis. Lung pathogenesis, the pathology, the two cells are affected, pneumocytes and the endothelium. Pneumocytes, this usually is attacked by the virus. The virus attaches itself to angiotensin converting enzymes by glycoprotein called the spike. And this complex goes to the angiotensin converting enzyme receptor on pneumocyte number 2 to invade it. This is the carrot, this is the glycoprotein spike attached to the angiotensin converting enzymes, and then come to the angiotensin converting enzyme receptor, invading the cell, damaging the pneumocyte number 2 with the loss or decrease in surfactant and induction of inflammatory reaction. That's why, here in this area, can we use angiotensin-converting enzyme inhibitor, which is used routinely in the treatment of hypertension? So, yes, might be of help. The second cell, which is endothelium of the capillary, this is usually affected, and we face what we call capillofalia. Capillofalia in the form of capillary leak to the interstitial, or leak to the alveolar edema, interstitial edema, alveolar edema. This is due to a large number of the excessive secretions of vascular endothelial factor, angiotensin 2, or beta-1 integrin. Treatment of such, this is a capillary leak. So far, no drug, but we usually adopt restrictive flow therapy. The last point, which is capillary obstruction by leukostasis, platelet aggregation, fibrin-clot. Leukostasis or aggregation of the neutrophils or the leukocytes usually can be prevented by corticosteroids, but it's not allowed. But we can use pentoxifylline, which can prevent priming of the neutrophils and interfere with this leukostasis. Platelet aggregation, for sure, we can use clopidogrel. Fibrin clot formation, which is a disaster here in this case, due to expression of tissue factor, this can be prevented by antithrombin or by the new oral anticoagulant drug like rivaroxaban. So my suggested protocol, in addition to the other lines of treatment, will be antiplatelet clopidogrel 75 mg per day, antithrombotic rivaroxaban 15 mg per day, anti-leukostasis pentoxifylline 400 mg twice daily, ramipril 1.25 mg per day if there is no contraindications. Before I finish, I can say, may Allah save us and protect all people on earth. And thank you.